Good morning, everyone. I'm Jennifer Walsh, Senior Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us this morning for a public briefing for the recently released report, A National Trauma Care System, Integrating Military and Civilian Trauma Systems to Achieve Zero Preventable Deaths After Injury. You can now download a copy of the report and other supporting materials at www.nationalacademies.org/trauma-care. Again, that's nationalacademies.org/trauma-care. You can also follow the conversation about our report on Twitter at #NASEM TraumaCare. For those of you not familiar with the U.S. National Academy of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The academies actually operate under a congressional charter to the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report's findings and conclusions, but before we introduce the committee, I want to go over a few technical aspects of the webinar. After the opening remarks, we will begin to take questions through the Q&A box located in the lower right-hand corner of your screen. Simply type in your question in the box at any time and click Submit. We ask that you leave the box set to send your questions to all panelists. And if you have any technical issues during the event, please contact WebEx Technical Support at 1-866-229-3239. Again, that number is 1-866-229-3239. So let me introduce the committee who have joined us today, and these are just several members of the committee that wrote the report. First, we have Don Berwick, Chair of the committee, and President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, and former Administrator of the Centers for Medicare and Medicaid Services. Also joining us is John Holcomb, a retired Army Colonel and Director for the Center for Translational Injury Research and Professor and Vice Chair of the Department of Surgery at the University of Texas Health Science Center. Also joining us is Jory Klein, Director of Nursing for the Trauma Center at the Parkland Health and Hospital System, and James Robinson, Assistant Chief of the Denver Health EMS Paramedic Division. Also joining us today is Autumn Downey, who is the study director for this report. So we'll start off with a summary of the report, and then we'll open it up to any questions that you may have. Please note that this briefing is scheduled to last for 1 hour unless we run out of questions beforehand. And with that, I turn it over to Dr. Berwick.
Thank you very much, Jennifer, and thank you everybody for joining this launch of the report. We think this is an important report, and we're glad to have your attention. I want to acknowledge first superb support from the Institute of Medicine and National Academy staff for this report. Beth Cornett, Autumn Downey, and Rick Erdman are with us today in this launch. And I want to acknowledge my colleagues on the committee, Jory Klein, John Holcomb, and James Robinson. We'll all pitch in to try to address your questions, and I'll make an initial set of remarks. We had a remarkable committee. I'll say there were 20 members of this committee representing a wide range of expertise in the area of trauma care and relevant policy and clinical leadership. I will say that we lost a member of the committee during our work. Dr. Norm McSwain, an icon in this field, unfortunately died during the committee's work, and our report is dedicated to Dr. McSwain. Two other preliminary comments. It would be impossible to be talking about trauma and trauma care in this country at this time without being very mindful of the tragedy in Orlando, and I want just everyone to realize our committee has that tragedy very much in mind, and it motivates us even further to make sure that care in this country for people who are injured is as good as it possibly can be. And a final personal comment, I'm neither from the military nor a trauma physician, but my respect and admiration for the people we're talking about, both those who serve and those who are injured in both the military and civilian side, is boundless and only grew during this inquiry. We really have great debt to the people who care for the wounded and for the wounded who have gone into harm's way. This report was sponsored by a wide range of organizations, both federal agencies and private sector civil society organizations, including professional bodies. I want to express the gratitude of our committee for the support of these sponsors and for their willingness to let us act without any interference whatsoever. This is a totally independent report supported by people that really care about the same topic as we're talking about. Our committee was charged with a rather complex series of tasks. Roughly, they were first to understand the ways in which the military especially has made enormous progress against the problems of management of injury and trauma. Underlies that in the light of the National Academy's framework called the Learning Health System. That's a technical framework that emerged about 2.5 years ago from another committee at the academies. And we use that framework to try to understand how progress is made in the military side and the civilian side. We also explored how we can do even better, so that what could be done in the learning processes on the military and civilian side to speed the growth of knowledge and better care across the spectrum of trauma care. We had a particular charge to look at the issue of readiness when the next war comes, though we hope it may not. If the next war does come, we need to have a military ready to get into action. And the committee is particularly interested in maintenance of readiness across time and space. And finally, to assure the bidirectional transfer of improvements in trauma care from the military to the civilian health sector and vice versa. And we've studied and want to comment on that process of shared learning. Let me acknowledge that this charge does not include a very important matter, and that is the prevention of trauma in the first place. Everyone on our committee knows that the best treatment of trauma, in a way, is not to have it happen in the first place through appropriate safety measures and protection, both in the civilian and military side. So we want to acknowledge the importance of prevention, but state that our charge had to do with the care of people who have been injured already in sustained trauma. In our conversation, I'm going to use a few terms that I'd like to spend a minute defining. We will be focusing, as you'll hear, on preventable deaths after injury. This has to do, as I said, with the survival of people who are wounded in the civilian or military side after injury. A preventable death is one which would be judged by clinical review to have been a rather complex term that we'll be using is focused empiricism. This is a term used in the military to describe the pragmatic way that military medicine has improved over time through the use of real-time data at the front line to learn, in essence, from every casualty. It is different from, although by no means contradictory to, more normal experimental scientific research. It's another way to learn, and we were specifically directed to understand how this method of pragmatic learning works in the military and how we could make it even more effective. And finally, we'd like you to understand that our committee chose to focus on the maintenance and support of an expert trauma care workforce. That means a workforce beyond simple familiarity or competence with trauma care. We're interested in making sure that every victim of trauma has access to the absolutely best expertise available. A little bit of background. This is an extremely important topic from the viewpoint of public health and well-being. In the military side, it's important. 6,850 service members died in Iraq and Afghanistan. Our committee estimates that at least close to 1,000 of them had potentially survivable injuries should trauma care have been absolutely at its best peak for every single one of them. That actually pales in comparison numerically to the civilian burden. On the civilian side, in 2014, 147,790, nearly 148,000 people in America died in deaths from trauma. We believe that about 20% of those deaths would have been preventable with optimal trauma care. That translates to about 30,000 preventable deaths after injury. To give you some idea of the level, of the nature of that burden, it is the largest cause of death for Americans under the age of 46 years. It is by far the largest cause of years of life lost because trauma affects young people even more than it does the old. And the financial costs of trauma are enormous, $670 billion of expenditure estimated in the year 2013. As you know, it's also relevant nowadays in everyone's mind with the presence of mass casualty incidents, which seize the public's attention and actually require the most expert possible trauma care. Let me point out that we have made tremendous progress on the military side. It's really dramatic. The case fatality rate in the military, the percent of wounded warriors who die as a result of their wounds, has fallen dramatically from 23% in the Vietnam War to 9.3% in the combined Iraq-Afghanistan conflicts. So major progress has been made. Our interest is in making sure that progress continues, is sustained, accelerated, and translated into civilian trauma care. Overarching our set of recommendations, which I'll walk you through, is a vision which we formulated that we need in this country a national trauma care system, one that unifies the efforts of both the civilian and military trauma systems with respect to intent, aims, infrastructures, including data management, system design, the availability and use of data, best practices, and personnel. I'm going to be explaining that overlap as we go through the recommendations, but an overarching idea is that we can't just improve one system or the other. The military trauma system and civilian trauma are inevitably connected, and they will be optimized together or not at all. And you'll hear a lot in our recommendations about a call for that level of cooperation, increased cooperation between the military and civilian system. So let me now take you through the recommendations. I will do them step by step. There are 11 of them. They will appear out of order because the logic actually favors that, so don't get confused. For example, recommendation 6 won't be discussed till nearly the end of my presentation. Our first recommendation, and maybe in some ways the most important, is AIM. We probably won't make progress against trauma care improvements without a national goal. And we propose a national goal of achieving 0 preventable deaths after injury and minimizing trauma-related disability. There is no agency in America capable of setting that goal that we can think of other than the White House. And so we are at first recommending that the White House should set a national aim of achieving 0 preventable deaths after injury. This is not impossible. It's a stretch, but it's not impossible. One of the compelling examples our committee got to study and learn from is of the 75th Ranger Regiment, led at that time by Colonel Stanley McChrystal, who took on the job as a line leader to aim for optimal trauma care for those Rangers under his command. And he achieved remarkable reductions, almost unprecedented reductions in preventable deaths in that Ranger Regiment. And we continually return to that example for what can happen when a real learning system is enabled for achievement of this goal under directed leadership with a strong goal. The second recommendation parses what we're requesting of the White House to consider down into specific tasks. The basic problem here is of integrated effort. Lots of different federal agencies and departments, as well as civil society groups, matter in seeking to pursue that national goal. In government, for example, there's the Health and Human Services Department, the Department of Defense, the VA, Department of Transportation, just to name a few. And there are many, many private sector organizations and professional societies that need to bond together in pursuit of the goal. We therefore ask that the White House lead that integration, especially of military and civilian trauma care, to establish the national trauma care system we envision. This would require that loci of accountability be established that ensure that system, the development of common best practices, data standards, an aggressive and well-invested research program in the country on trauma care, and workflow across the continuum of trauma care, and that'll be more clearer to you as I proceed. So the first two recommendations refer to White House leadership of a national aim and the establishment of a system of trauma care in the country. Recommendation 3 takes that goal and now maps it over to the Department of Defense. As I've said, DoD has made tremendous progress in in the treatment of military casualties with great results, but it can do better. We are asking for increased clarity in the line of responsibility and accountability for the execution of a trauma care system capable of achieving 0 preventable deaths. That activity has to begin with the Secretary of Defense, because that's the only level that can make it absolutely clear that there needs to be cooperation between combatant commanders and the Defense Health Agency to hold responsibility and accountability for the integrity and quality of such a trauma care system. In essence, the combatant commanders set the specifications for the results needed, and the Defense Health Agency acts in its support role to make sure that those results are delivered, and we are seeking absolute clarity about that goal and that line of accountability. On the civilian side, the accountability is harder to establish because there is no single agent overseeing American healthcare as there is military healthcare, but we think leadership is necessary and possible, and we have chosen to suggest that the Secretary of Health and Human Services, under the President's directive, should designate and support a locus of responsibility and authority within HHS for leading a sustained effort to achieve a national aim of 0 preventable deaths after injury and minimizing disability. That is a coordinative function. It involves governmental and non-governmental agencies, and although we suggest it be located within HHS, we fully understand this involves cooperation across many federal bodies, as I said earlier, between HHS and DOD, including the Veterans Health Administration and the Department of Transportation, just to name a few. The first 4 recommendations have to do with localizing authority and responsibility for pursuit of a national aim declared by the White House. Now we'll get into some of the details about the implementation needed to accomplish that aim. Recommendation 5 speaks about data. To have a learning system that can improve regularly over time, you need information about what's happening and what the results are of changes as changes are made. So we're recommending a much more integrated view in the nation of trauma data across the continuum of care that especially includes pre-hospital care, because a lot of the preventable deaths that occur in trauma care occur before people reach hospitals. And at the moment, the pre-hospital phase of care is not fully integrated enough with the hospitalization and post-hospitalization phases. We need one data system, and viewing this as a care system across the continuum. And the data sharing, we think, ought to be also between military and civilian sectors. There are some limitations on that, but overall, the nation will make faster progress if it shares a common data set on trauma care spanning the entire continuum of care, from injury to post-acute care, and which melds together information for both the military and the civilian sector. Next recommendation, I've skipped 6, we'll come back to it later. Recommendation 7 has to do with the research agenda of the nation on trauma care related to the earlier comment on data. Right now, the nation is seriously underinvested in trauma research. Remember, this is the largest cause of death in people under age 46. It's the largest single cause of years of life lost at a $670 billion cost to the nation, and yet we do not have a cogent or well-designed national research strategy on trauma care. In the National Institutes of Health, if you rank order topics that NIH invests in, there's a chart in our report showing 27 topics that NIH investigates, cancer, lung disease, heart disease, and so on. Trauma care is listed. It is number 27 out of 27. And we recommend a rebalancing so that to ensure that the resources available for trauma research are commensurate with the importance of injury and the potential for improvement in patient outcomes. 30,000 preventable deaths in the civilian side, for example. How to do that? The White House has had a track record recently of establishing national research action plans. There is one, for example, for traumatic brain injury, and we think this would be appropriate to use to create a national trauma research action plan to coordinate the research endeavors of federal agencies like DOD and the HHS operating divisions, the Department of Transportation and the VA, and by the way, to include and reach across to academic institutions, private research organizations, and professional societies. This would be a national trauma care research action plan in consonance with the aim of 0 preventable deaths after injury. To do that correctly requires some adjustments, we believe, in the regulatory environment for research and data management. We have complete respect for the needs for privacy, patient safety, regulation. Patient should have control over what changes could be made in oversight by the FDA, by DOD, and by HHS with respect to human subjects rules that would allow faster progress, and especially faster progress using the thing I mentioned earlier, the method of focused empiricism, learning from and acting on data from the field. This is a rather technical matter, but we strongly suggest that those setting these rules in place and currently revising them think hard about the effect on the ability to learn in real time from the real events that are occurring both on the civilian and military side in trauma care. I'll take note that the National Academies currently have a committee that is specifically looking at human subjects protection and the so-called common rule, and we are essentially expressing our hope that that work proceeds with full regard to the importance of focused empiricism as a method of learning. Transparency matters in a learning system, and Recommendation 9 speaks about the availability of information for improvement and especially the support of learning systems in the nation, including the military, to study and learn continuously about the improvement of trauma care quality. Programs exist. The best known is the American College of Surgeons program on trauma, the Trauma Quality Improvement Program, TQIP. Very little of military trauma care is currently involved in TQIP. We think that should become a standard, and we encourage expansion and complete investment in quality improvement processes that share information and learning across the actors in the trauma systems, both military and civilian. There's a particular opportunity for Medicare and Medicaid to help here. The Centers for Medicare and Medicaid Services, we believe, can and should pilot, fund, and evaluate regional and system-level models of trauma care delivery, including the continuous learning processes we're talking about. In other words, we have a chance to have very important demonstration projects on the pursuit of the goal of 0 preventable deaths after injury. One of the key learnings in our inquiry was the importance of pre-hospital care. Many preventable deaths occur before anyone ever gets to a hospital, and only attention to and improvement of pre-hospital care can achieve the goal. And yet, if you look at the way we're currently structured and financed in healthcare, pre-hospital care, emergency medical services tend to be regarded actually more as a transportation. The military's ability to project very expert care out to the field, right to the support of a medic on a bended knee next to a wounded warrior, has made a tremendous difference in outcomes. And progress is occurring in the civilian emergency medical services. You saw what happened in Orlando. You saw what happened with the marathon bombings in Boston. Those improvements actually largely rested on lessons that had been learned in the military that were effectively brought into the design and conduct of civilian emergency medical responses. But we need more of that and more support to the pre-hospital phases of care. And so we're recommending that there be consideration given to some pretty important changes in policy. For example, could the Social Security Act be amended such that emergency medical services are identified finally as a provider type, because that's what they are, establishing conditions of participation and oversight just as we do for hospital care. We have to look at payment and the way in which we fund and support services, which in fact are far more than transportation services. Back to Recommendation 6, taken out of order here. This has to do with the availability of knowledge about best practices and data at the front line. It's not enough that registries of trauma care research functions occur at some central place where investigators and reviewers understand what's going on. That knowledge has to reach the sharp end. Every single provider of care has to have access to real-time data, not just about patients, but about trauma care standards, the knowledge base that allows trauma care to be given at its best. The military has a superb record here. The Joint Trauma System is a very important asset within the military that allows for this real-time point-of-service learning, and we think that should be part of the National Trauma System, and that the Defense Health Agency and the military should take should be seriously concerned that the Joint Trauma System, for example, continue, and we need similar kinds of functions in the civilian side. Finally, recommendation number 11. You remember that part of our charge was to assure readiness, to assure that that on day one of the next war, the trauma teams that the military is able to deploy to the sites of combat have world-class expertise, at least at the level of the care of the last wounded soldier in the last war. Not to lose the lessons learned, but rather to build upon them and assure that continuity over time. That is very difficult. The reason is that the military, during peacetime, and possibly even during wartime, but during peacetime, does not have the volume of trauma cases that allow expertise to be retained. So the doctors and nurses and managers and pharmacists and others that are key to expert trauma care don't practice. They don't have a chance to continue their learning. New entrants into the military health system don't have that exposure at all. And we don't believe that the nation can retain readiness at the expertise level we imagine with that current system. It just isn't possible. And so we're recommending a new relationship between the civilian trauma care system and the military health system such that military health trauma teams, not just physicians, but physicians, nurses, managers, therapists, these teams would be embedded, permanently embedded, in civilian trauma centers, level 1 trauma centers at least, so that they can participate in the care of trauma victims on the civilian side and thereby not only help civilian care, but in addition maintain their readiness to be deployed with high levels of expertise on day one of the next conflict. Let me point out that system exists. We have a small number of level 1 trauma centers in the country which do have embedded military personnel maintaining their skills and readiness, but it's not at the scale needed to promise the war fighters of the next war that they'll have the trauma care that they should have if we can maintain all levels of expertise. So that's a particular recommendation for action on a platform for maintenance of readiness. That's our report. We're happy to take questions. I'll invite my colleagues from the committee to weigh in with anything they think I skipped here that they want to comment on before we take your questions. Let me point out that the slides I've just shown you and the PDF of the report are available now as of the 11 o'clock this morning on the website shown here, nationalacademies.org/trauma care. So you can now have access to everything you have just seen. Jennifer, I'm happy to take questions. Let me ask Jory, John, and James if they have anything they'd like to add at this point.
No, sir. I think you did a great job.
Jory, please go ahead, Jory.
I was just going to comment that I think you covered everything in a level of detail that lays the groundwork for what we need to do.
Well, thank you. So please, Jennifer, back to you, and I'm happy to help respond to questions if there are any.
Sure. We are taking questions now. As a reminder, you can type in your questions in the Q&A box in the lower right-hand corner of your screen. I ask that you please identify yourself and your organization while you're asking a question. So we do have a few coming in. The first one is from Tinker Reddy. What is the most important message in the report for hospitals?
For hospitals. I think I'll take a guess and then ask John and Jory and James to please weigh in. We can't get the job done of zero preventable deaths without thinking of trauma care as a system. As important as hospitals are in the system, it's important for them to see themselves as part of a continuous pathway of care that begins at the point of injury, includes pre-hospital care and post-hospital care. And that systems view, I would say, would sound crucial to me in terms of the role of hospitals. The other is many lessons that are being learned in military medicine have been translated in the civilian sector, but not all, and not all at the level of fidelity we would want. I'll take, for example, tourniquet use, which has been a major improvement in the military side, since hemorrhage is the most common cause of preventable death in the pre-hospital phase, at least. Tourniquet use around the United States is not consistent, and I think hospitals may well have a role to make sure that it becomes so. Let me ask James and John and Jory if they would please add your thoughts.
Yeah, it's John Holcomb. It's a great question. I think that besides what Don answered, the integration of the military and civilian systems of care, extremely important throughout the entire continuum of care, pre-hospital, hospital, and post-hospitalization recovery and rehabilitation. But this idea of integrating, not forming one system, but that overlapping Venn diagram of military and civilian systems for the hospitals, I think, are extremely important. Bringing those entire teams, nursing, medics, docs, administrators, into civilian, high-quality, high-volume centers for training and full-time participation of those military teams before they deploy to war.
If I could just add, it's James Robinson, that I think Don articulated it perfectly, that the systems view is the most important component of, I think, probably the most important point we made through the whole report. And in the civilian world, on a smaller scale, often care that's provided outside the hospital is viewed in a silo, as well as the care that's provided in the hospital. And until we look at the full spectrum of integrated care from the point of injury through the discharge of the patient back into their civilian lives, we're still missing the mark.
Jury, do you have a comment?
Yes. Again, I think you covered it very well. So I think systems of care is what saves people's lives, whether they're civilian or whether they are in the military. So everywhere the patient goes, every echelon of care as the patient moves, needs to have a good understanding that they fit in a system, and it's about the patient. And then the other issue that we've touched on in our report, and I think we need to highlight, is data. So my belief is that data drives the system. It is the DNA of the system. If it is strong, there's a good DNA is strong, then obviously we're going to have a developing system that is robust. And if the data is weak and therefore the DNA is not strong, then we're going to have something that begins to crumble fairly fast. So again, systems of care with data that drives the system.
Please understand, building on Jerry's comment, that the current data systems for pre-hospital care and in-hospital care do not interface well. There is no single system that allows you to say this person was injured in this point and here's their care all the way through. And I would ask hospitals to please commit to building integrated data systems for the pre-hospital and post-hospital phases.
Right. Yes, Don, this is Jory. I also want to emphasize that the rehab data also needs to be integrated. And, there's been a focus on pre-hospital, but our report did not focus on the rehab piece of it, but that is an element that needs to be added as well.
Including medical examiner data, by the way.
Yes.
Okay, our next question comes from Aaron Padua-Evan. Are you finding it easy for military staff to get state certified for ease of transition of a workforce?
Let me ask John and James to comment on that one. Yeah, Aaron, it's a great question. This is John Holcomb. Easy is a relative term, obviously varies from state to state. I would say it's doable. At each state, satisfying the individual requirements. One of the interesting opportunities for the military folks under federal orders to practice at a level 1 center would be to have some change in the rules and the requirements, allowing their federal status to allow them to practice at a state level. That's for future opportunities.
James, what are you seeing on the pre-hospital side?
This is still a problem that we haven't tackled, and I think there are some good efforts underway. I think there was an effort spearheaded by the First Lady to more rapidly transition military EMS providers into the civilian sector, but those efforts are ongoing and incomplete, and they need continued attention and effort.
This is Don. Let me say this might be an example of recommendation 2 at work. You would need a centralizing leadership force for creating this kind of continuity, and you'll notice personnel is one of the topics that we think the White House would want to take on or oversee for the purpose of creating a system to achieve zero preventable deaths.
Okay, our next question comes from Don Jenkins. He asks, when the report says establishing a national research investment towards trauma and injury that is commensurate with the burden that the condition has on the nation's health and well-being, can you make an estimate as to what that might look like, and would it be DOD or NIH based? We
struggled with an estimate. Our report says that a rational estimate should be made that this should be taken under consideration in a national trauma plan. It's some multiple of the existing investment. If you read the report, you'll see how really minimal the current investment is, but we don't have an actual number. I would say the investment will be all of the above. Certainly NIH and DOD does have active trauma research, which needs full and ongoing support. And I would say some of that investment also needs to go into the common data system that Jerry Klein was talking about earlier. I know John Holcomb has thought a lot about this, and John, please comment.
Yeah, it's John Holcomb. In the report, we document where federal funding at the NIH sits out of 27 disease processes. As Don said earlier, it's 27 out of 27. That's been documented now for many, many years, to include a paper going back to 1976, I believe, from Don Trunke in Scientific American, documenting the exact same thing with the imbalance of the societal impact and federal funding at the NIH. So, you know, I think that if you look at the data that talks about the number of deaths and preventable deaths, both on the military and civilian side, the research investment should come from both the military and the National Institutes of Health to focus on these trauma deaths that have such a huge impact on society, especially the potentially preventable deaths that occur pre-hospital, hospital, in both environments, and it's required collaboration between the two agencies of the federal government, NIH and DOD, to solve this problem.
John mentioned the investment that I mentioned earlier. That's chart 4-7 in the report. If you get the report, you'll see the degree of investment in these 27 categories of research that give you sink your teeth into. John also mentioned something I want to highlight, which I did not say in the opening remarks. This is by no means the first report on improving the nation's trauma care system. There is in the full report a actual pedigree diagram going back decades showing the series of reports which have not been acted on. And I think I'm fairly representing the committee's views that we're rather impatient that it's time to do something. The meter is running on these preventable deaths, and we really hope that this not be just the next in a line of reports in which no action is taken. This should be the beginning of real change that so far the nation has not undertaken.
Particularly, this is James Robinson, but particularly in light of the fact that this year marks the 50th anniversary, my EMS colleagues on the phone will appreciate of the 1966 paper, Accidental Death and Disability, the Neglected Disease of Modern Society, that kind of started EMS in our country in its current form.
Our next question comes from Peter Hedberg. He asks, the Armed Forces Reserve System seems to be an important part of making the Armed Forces ready for the next conflict, as those providers can be in busy civilian practices until needed. If agreed, how is this able to be strengthened?
Yeah, it's John Holcomb. You know, the reserves are a huge part of the military's ability to respond to combat casualties, both in an emergency and in a pre-planned fashion. Many instances represent 60% or more of the forces on the battlefield at any one time. The reserves forces have a wide variability of experience, as we document in our report. Some of the reservists work at level 1 trauma centers and are the most highly trained and capable forces, individuals and teams in the country, and others have a practice that is much more an elective nature, no matter what their specialty is. So I think one of the challenges that we talked about in our report is understanding that variability experience, documenting that variability experience, and then deploying those reservists as experts, having expertise in trauma care to the battlefield to optimally care for combat casualties. It's a great question.
Our next question comes from Anthony Bevers. He's a paramedic who trains local police officers. He asks, if the executive takes your recommendation for mandating 0 preventable deaths, what do you see as challenges that may come between the White House and the police officer or civilian on the street?
This is Don Berwick. I'll take a stab. I suspect that the goal would be welcomed. I suspect that the frontline first responders who carry a lot of the burden for this would want to be part of a system that recognizes their contributions and allows them to integrate more thoroughly into the efforts of the rest of the system. So you may have in mind barriers that I'm not quite so aware of, but I think we have a terrific workforce out there that actually wants to do better and needs this kind of national leadership in order to come together and be the system that I suspect they want to be. James, you live in that world. What would you say?
I would agree with you, John, and I would add that if you look at the trauma chain of survival, and there's a figure in the report, it begins with the bystander. And I think you've seen national initiatives like the White House Stop the Bleed campaign and the increased training of civilians in hemorrhage control techniques and the proliferation of tourniquets in the public sphere. All those things actually strengthen our nation's capabilities to respond to events. And so I don't see a conflict with the White House at all and the people on the street. In fact, I see the implementation of our recommendations as aligning the national effort in concert with the aim that we recommend in recommendation 1.
James is referring to a diagram in the report, figure 2-1, which shows that chain of survival extending all the way back to the role of the bystander.
John, can I elaborate on that?
Please, yes.
Yeah, so it's John Holcomb. I agree completely with what James said. You have the Hartford consensus work that's going across the country. You have the White House Stop the Bleed work. You have police officers stopping bleeding at the site of injury, either with compression, manual compression, or tourniquets by police officers, and civilians with some medical training or little to none medical training intervening as well. There are pockets in the United States where this is happening fairly routinely, being publicized, and there are unfortunately pockets in the United States where it's not happening. And what our recommendation really talks about is leveling the playing field across the country, where you're injured shouldn't determine if you live or die, right? Especially with potentially preventable injuries that are fairly easily controlled with lessons learned on the battlefield in hemorrhage control and extremity injury, et cetera.
So the best of civilian trauma care is superb, but it's variable, highly variable around the country, and our committee does have that line that John mentioned, which is where you live shouldn't determine if you live. And right now, too much it does.
Thank you. Our next question, we actually have a couple of participants who asked the same question. First is Jeffrey Shea from Banner University Medical Center and Rajiv Gupta. They ask, what are the next steps from here, and how can regional trauma committees and academic trauma centers support these initiatives?
Our committee's recommendation about next steps significantly include White House leadership for establishment of the national aim and the convening of the various parties that have a stake in this around a common aim and a common design of the system, and that would be catalytic and crucial. I will guess and defer to my colleagues that what we're calling for, integrated data, high levels of cooperation between pre-hospital and acute and post-hospital care, standardization of protocols and guidelines so that they reach the absolute level of success that the TCCC, the trauma casualty care standards in the military have reached. These agreements, these visions could be at state and local level better with national leadership, but I'll assume that any regional group that cares about their community could read our report and make an action list they can take action on right now.
Yeah, it's John Holcomb. I agree completely that, the United States trauma community is largely divided up into regions where you have a coalition of those pre-hospital, hospital centers that work in that region, and many of these recommendations can be implemented at the regional level with the ongoing existing infrastructure. The American College of Surgeons Committee on Trauma has trauma regions across the country as well. And the American College was one of the important co-sponsors of this report, and I think we'll take some action. So as everybody in the room and on the line knows, the best way to accomplish one of these calls to action is if you have work at the ground level and then work at the higher level, and they meet in the middle, and all of a sudden lots of good things are happening. And that's, I think, as a group, what we hope will happen here.
Jerry Klein, can you weigh in on this?
Sure. Sure, I would love to. So to me, there are 4 levels of system that we need to talk about. And so we've already talked about there needs to be national leadership, and so let's talk about the state. So the state leadership needs to look at these recommendations, and I would encourage them to also pull out the HRSA Model Trauma System Plan and use that as a guide and ask, you know, where our weaknesses are, and it's going to be easy to identify. And to me, again, the focus should be on making sure that we have integrated data so we can evaluate our systems. And then it goes to the regional level, as Dr. Holcomb has talked about. The region usually ties into what the state has mandated, and then finally to the local level and to the trauma center. And again, in each one of those elements, those critical elements of the Model Trauma System Plan and data needs to be focused on and ask the question of what's missing, what do we need to work on, and what should be our highest priority to make sure that we fit into the National Trauma Care System Zero Preventable Death, published by the National Institute of Health, the National Academy of Science.
Can I jump on this one more time? The ability to take action at the local level. Have you seen this happen? Are there regions of the country where people really have gotten together to do this that you would like to refer people to?
Well, this is Jory. Go ahead, John.
No, Jory, go ahead.
I was just going to say that I think that, you know, I know that Florida has regional systems. I know North Carolina has regional systems. Certainly Texas has regional systems. Those regional systems report to the state. And again, it goes back to, you know, the states are mandating and driving the system now. So if there was a national focus with national standards that pushed it to the state, then I think we would have more states aligning to create these regional systems. And those regional systems is where you have that multidisciplinary participation that comes from fire, police, you know, the healthcare workers, the trauma surgeons, the emergency medicine, all of the nurses align, the paramedics, the air medical. That's what makes the region strong. It's when you have that multidisciplinary group come together to look at these examples of what should we do and where are weaknesses and what does the data show us, and more importantly, what data do we not have that we need to make decisions.
Thanks, Jory.
Our next question comes from Sherry Fink for the New York Times. She asked, the estimated number of needless deaths is impressive. Can you talk about how you reached that estimate? And what are people dying, what if people are dying needlessly, and in those cases, what should have been done that could have prevented those deaths that wasn't done?
Yeah, it's a fabulous question, John Holcomb. You know, on the military side, we had the benefit of the publications by Brian Eastridge and others that went through every one of the deaths from Iraq and Afghanistan. That was possible because every death had an autopsy. They were all done in one place. The reports were available for review. And what was found is the leading potentially preventable cause of death, both on the battlefield, pre-hospital, and in the hospital, was from uncontrolled bleeding. And so the DoD then took that and focused their research and performance improvement and quality efforts on stopping bleeding both pre-hospital and in the hospital by various mechanisms. Despite all that, and because of the 15 years of war, there were still 1,000 potentially preventable deaths on the battlefield, more so earlier on than later on. Now, in the civilian world, there are pockets of places that have done similar types of research, but there's not a national compilation of data. This is why our efforts and when our specific recommendations on data permeate the report. So there are cities that have done this. They talk about a 30% potentially preventable rate in a city, but across the nation, there's not a national compilation. Our best estimate from papers that have done this is a 20 to 30% potentially preventable rate, yielding that 30,000 potentially preventable deaths in 2014. That doesn't include the pre-hospital area because we don't have a national estimate from the pre-hospital area, so that's going to be underrepresented. I know that's a long answer. I apologize, but it points out the lack of available data, and it also highlights the huge opportunity to save many, many lives from these preventable trauma deaths that occur every day.
This is Don Berwick. I'll just add that the tone of the committee in looking at this is that although we don't have the exact data, there's quite a high level of confidence in the committee that the estimate of 20% preventable translates to 30,000 civilian deaths is conservative. We think that's a pretty solid estimate. And John, in terms of the methods of death that could be rendered, it's hemorrhage and what else? What categories?
Right. So trauma patients die early from hemorrhage and head injury, and be that on the battlefield or in the civilian sector. It doesn't matter the mechanism or the wounding agent. That's why humans die early. The potentially preventable largely falls in the bucket of the hemorrhage, and a lot of it is extremity hemorrhage. And this is where the emphasis on tourniquets, which are not the be-all, end-all, they're not going to save everybody, but they will save a large number of patients who needlessly bleed to death from extremity bleeding. That is the message that we found on the battlefield, and in the pockets in the United States that have done this, that's a message found in civilian trauma as well. I would go on to say that if you continue that math exercise, you end up with 81 patients a day dying in the United States every day that are potentially preventable.
There's 400 trauma deaths a day, 81 preventable is the estimate we're using. The other advances the military have made that have made their way into civilian care but not as completely as they want have to do with the use of blood products and fluid resuscitation techniques at both pre-hospital and in-hospital, and management of airway and pneumothorax.
I would just like to comment about the data. I know that if you look at some of the other diseases, there are published outcomes that the public has an opportunity to review. That is not true for the trauma centers. The TQIP model is giving us information in the trauma centers to be able to benchmark ourselves. So with this new recommendation, if there was an opportunity to have that data in select fields that we're going to publish so that the public can see that, again, we can educate our consumers about where the best practices are and hopefully improve trauma care across the board.
Thank you. We actually have had a couple of questions come in that has asked about rural trauma systems and what recommendations and findings are in the report address rural systems and what resources can be tapped into to help with improving rural trauma systems.
James, you want to?
Yeah, I come from a state where we have lots of rural and frontier areas in Colorado, and you know, it's a challenge. It's something that we really don't know what we don't know yet, and we need more data. We know that from the pre-hospital perspective, it's hard for us to definitively say what interventions provided earlier on, what resources, et cetera, would improve the longitudinal care of patients from the point of injury through their release from rehabilitation. One of the recommendations that we have under Recommendation 10 that deals with EMS and pre-hospital care is that we need a national EMS assessment that would determine what types of resources, support, training in the pre-hospital setting that would have definitive impacts on ultimate patient outcomes. And so I think those are the things that we need in the rural setting as well as the urban settings. And looking at it from a systems perspective, there are things that we know about rural trauma systems. We know that it requires movement of patients and handoff of patients to different levels of care. And as I think there's a military analog for that, and the military has done a really good job of figuring out those different roles and levels of care, and that's a model upon which we might be able to build in the civilian sector.
That ability of the military, this is Don Berwick, to project care at the appropriate level of intensity at various levels from the point of injury to the quaternary medical center has been one of the breakthroughs in achieving results compared year on year in Vietnam to Afghanistan. Military is able to get care to extremely austere and dangerous environments at exactly the right level in a timely way, and it's a good model for building the regional systems we're talking about. John, do you want to comment on rural care?
You know, I come from, John Holcomb, I come from Texas. We got a lot of rural parts of Texas as well, even though I live in Houston. And you really have this confluence of transport time, training capability, distance, weather, that really makes pre-hospital care much more difficult in rural America. At the same time, those opportunities and lessons learned in the military, I think, can be almost immediately applied in rural America, those lessons learned in stopping bleeding, especially from extremity areas.
And Don, this is Jordy. I just want to comment, too, that as John Holcomb pointed out, the Texas system does have a lot of rural areas, but the systems of care and coordination of those rural trauma centers into the larger trauma centers and the communication back and forth and the shared experiences between those facilities obviously improves patient outcomes. So again, to me, it goes back to these systems of care that we're talking about.
Thanks, Jerry.
Thanks. Our next question comes from Marie Steiner from the University of Minnesota. She asks, to train and maintain skill sets, do you envision high-quality stimulation exercises playing a role? Or, sorry, high-quality simulation exercises playing a role?
Yeah, it's John Holcomb. I'm a firm believer in simulation. As I spent 23 years in the military, we did a lot of work with simulation, both medical and non-medical. And, you know, simulation has an absolute role. We discuss it in our report, albeit not in great detail. Simulation is a bridge, I think, between sitting in a classroom, reading a book, getting into the simulator, and then heading off and really taking care of patients. It is not the be-all, end-all. I don't see it as the end state, but it is a bridge to putting those teams into high-quality centers where they can take care of patients in the highest quality fashion.
Our next question comes from Lynn Drake. She asks, the definition of preventable death can hopefully be changed as new strategies and technologies emerge. Do you envision an integrated military civilian trauma system better clarifying the specific needs for new research?
Definitely, yes. It's important to invest more in trauma research, we believe, and to be clearer about purposeful research that's directed at where the needs are, and they're both incorporated in our report. John?
Yeah, it is an absolutely fundamental question. Again, to repeat what I said earlier, Brian Eastbridge and others did a great study of thousands of deaths in the military, and from that developed research programs, intervention programs directed at those potentially preventable causes of death. We need to do exactly the same thing on the civilian side. One of the struggles that we identified, one of the issues we identified in our report is the need for a complex time between the medical examiners and the clinicians and the research scientists, allowing us to communicate in a common language, generate a database, there's that word data again, so that we can rapidly develop interventions, programs, systems to decrease the huge number of preventable deaths across the United States.
Thanks. I also have a question. If you can please restate the title of the list that you talked about, I believe was funding for research for trauma was number 27 to 27. Which list was that?
The list of the projects that are supported, the project areas are supported by the National Institutes of Health, and it is incorporated into our paper. We actually reproduced the diagram itself, and I don't have the page. I'll give you the page number in a second. We're looking up the exact location of the. It's diagram 4-7 in the report. It appears on page 4-33 of the version I have, and it shows NIH funding for medical conditions relative to the total disease burden. And you'll find injuries at the very bottom, 27 out of 27.
Our next question comes from John Parrish. He asks, should we consider some of the deaths that occur in skilled nursing facilities preventable, such as those with minimal consciousness who are under CMS regulations that go to skilled nursing facilities, not rehab hospitals?
Yeah, John, this is John Holcomb. Another wonderful question. You know, I would say we're looking at this, and others have looked at this, especially in elderly patients with repeated falls. You could talk about potential preventability in those cases. It becomes a somewhat complicated answer we did not address in our report of location of death in relation to potential preventability.
Well, we are at the top of the hour, and I know that there were a lot of questions that we weren't able to get to, but I want to thank everybody for submitting their questions. And like I said at the beginning of the webinar, the committee members who served on our study served pro bono and volunteered their time to carry out the study. So a big thank you again to all the committee members who served, and thank you for participating in today's webinar. And once again, you can receive all these materials at that link that you see on the page, nationalacademies.org/trauma care. Thank you for joining today.